In this video, I'll talk about the anatomy and what an injector should know about the different planes that we inject. Injecting filler in this area is associated with skin necrosis and blindness. Filler migration is reported less, and this has to do with the superficial placement of the filler. Knowledge in anatomy and then experience is crucial. Before injecting this area, one should know the detailed anatomy. Once you know the anatomy, then attend a workshop and inject under supervision, and finally attend a cadaver workshop. There are 4 different planes to place the filler, and there is no safe plane. The first plane is in the superficial fat plane, the second one is sub-deep fascial plane, the third is a supraperiosteal plane, and finally perhaps the interfascial plane. Bear in mind the patient wants a satisfactory cosmetic outcome. They don't really decide on the planes that you put the filler in. Understanding anatomy is key regardless of the approach or the technique. And there are pros and cons regarding each plane. Let's first address the elephant in the room, which is the most important structure that we all want to avoid, and that is the frontal branch of the superficial temporal artery, which is in the superficial temporal fascia. You may want to refer to the Anatomy for Injectors module for detailed explanation and video demonstration. The most common plane being injected is in the superficial fat plane, and this is usually with a cannula to avoid bruising. The advantage of injecting in this plane is such that the filler is placed above the superficial fat plane where the artery is. However, the downside is if a patient has severe hollow, and especially if one uses a thicker filler, then the result can be very lumpy, and this is not easy to massage away or get it even. And often in these cases, the patients with superficial veins will become even more prominent after the filler injection. There is another less well-known plane that we inject filler into, and this is the sub-deep fascial plane. The advantages of using injecting in this plane is that minimal filler can be used. This will give best even results. The filler simply glides beneath the deep fascia and can be evened out evenly. The downside is that one has to use a needle to pass through the deep fascia, and obviously one has to go through the plane where the superficial temporal artery is. And supervised training injecting this plane is highly recommended. Another well-known injection is to place the filler onto the supraperiosteal plane, which is also known as the gunshot area. This has been touted to be safe, but in actuality it is not, because we use a needle and it has to go through the superficial fascia where the artery is before we can reach the bone. And technically, this is also an intramuscular placement of the filler, because the filler is placed in the temporalis muscle. Therefore, spreading the filler within the muscle fibers is not as easy. The entry point for this injection is usually 1 cm below the temporal fusion line and 1 cm behind the orbital rim. It does present a challenge, however, if the patient's temporal hollow is not centered in this area. Therefore, if one injects too superior to this point, the filler may be trapped between the fascia and the bone, causing headache. And if one injects more inferiorly, this creates a danger of hitting the temporal vein. Some injectors, especially those with ultrasound, has talked about an injection in the interfascial plane. That is, the placement is supposed to be between the superficial and deep fascia. One has to remember that these 2 layers are tightly held together, and the artery is somewhere in between these 2 fascia. In summary, One should not underestimate the complexity of anatomy in this area and do not put the patient at risk.